Thank you. It's a pleasure to be here again. Now, what I would like to do is cover a few things. Some of these slides were originally prepared when I did a psychoimmunology research presentation to a group of international researchers. So I'm going to change it some from what's in the book and try to cover it fairly quickly and touch on a couple of clinical issues in the tail end. So I'll touch about pathophysiology and looking at two areas, inflammation and autoimmunity, as a why and wherefore, and touch on a couple of conditions, autism, dementia, violence, and summarize some things. So this is my first job, my first paying job after I was a doctor was at a place called the Eastern Shore State Hospital in Cambridge, Maryland, on the banks of the Choptank. And I worked here doing moonlighting from 72 to 75 while I was a resident in Baltimore. And I would come down here and be the only doctor on call, sometimes for the evening or for the entire weekend. And it was quite an interesting job, and I saw a lot of things that raised my curiosity. When you would go in the building, the grounds, the first building on the left was the child unit, and there would be a lot of autistic children there. So what caused that? There were also developmental disabilities. I remember one patient, he was locked in an attic, or he chained in an attic for years, and then his parents died, and then they discovered him, and he would sit on the bench outside here, on the concrete bench, and stimulate himself, and what caused that? Another case was a woman who, I was on the geriatric unit, and I heard someone barking in the corner. And I thought, that's odd. So I went over, I spoke to her, and I got some history, and she said, oh, you're from Shepherd Pratt, you know Dr. Sullivan, Harry Sullivan, he's my doctor. I said, well, he was a little bit before my time. And I went back and I looked up her old record, and she had done a grand rounds at Hopkins in 1929, and it described it. And she was a Radcliffe graduate who then had this abrupt onset of symptoms that included tics, and it included panic attacks and obsessing and anxiety. And then she was through the private hospital system and gradually spent her life and spent basically the rest of her life, like 50 years in the state hospital system. And it was tragic because something like this we would treat very differently today. Another case, remember a couple of violence cases. One case I remember looking out the window, and my on-call quarters were above the admission unit, and I saw 3 Maryland state troopers wrestling this guy into the admission office, struggling with all their strength, and obvious case of explosive rage. And then about an hour later, I saw this 70-year-old female nurse calmly escort him to one of the admission units, and he was quite peaceful at the time. Another violent patient was a fellow who his problems began with joint pain, and he became self-conscious because he had time management problems. He had trouble getting places on time, and he would arrive at church late, and he would walk up and try to sneak in late, and his joints kept cracking, and everyone would turn around and look at him. And then it gradually developed more. He had more cognitive things and mood problems, and then he became quite psychotic. He was inserting foreign bodies in various body orifices and was quite delusional. He had a tendency to jump out windows. And it was always puzzling what caused that. In addition, there were a lot of dementia cases, and some were what we called pre-senile dementia. I would see people that would be like 40 years old who had dementia. And one patient on the geriatric unit, he was walking up the hallway, and there was a string in the corner of his mouth, and what is that? So we looked in his mouth, and it was a mouse. And he was so impaired, so demented that he didn't put together what was happening. It was actually previously a very high-functioning person. Family came to visit him about an hour later. We didn't tell him about the mouse. But there were a disproportionate number of these dementia cases here. that particularly raised my curiosity. Now, maybe I should have called the CDC and said, why don't you come out here and investigate all this? But I don't think they had the interest in mental illness like they would of arthritis. I should have emphasized the arthritic part, and then we may be having a conference on Cambridge disease today instead of Lyme disease. So the question was, there was a lot of suffering, and then a lot of these patients would end up on what we call the medical intensive care unit, where you could walk in a unit and smell gangrene because of all the bed sores. And so this was a place of a lot of questions, a lot of pain, a lot of suffering. So now, today, same place, but it looks a little bit different. And instead, we're hopefully, instead of the suffering and pain, we're getting answers to some of these questions. And it's a resort setting instead of a place for a psychiatric hospital. So let's look at Lyme disease a minute. And based on objective testing, Lyme disease, functional disabilities as severe as congestive heart failure, pain as severe as post-surgery pain, fatigue as severe as multiple sclerosis. And from the psychiatric perspective, there's over 300 peer-reviewed journal articles now connecting the association between Lyme, tick-borne diseases, and psychiatric illness. Now, I want to draw attention to two studies that are really quite interesting. There's basically the most common pattern that we see with the presentation of Lyme disease, and then there's uncommon patterns. The most common pattern is pretty much summarized in these two studies that are really 23 years apart. So basically, you see, as a later manifestation, encephalopathy, emotional symptoms, fatigue, and irritability. For example, this was one in 1990, and a high incidence of encephalopathy broken down with memory problems, word-finding problems, the usual things that we see: fatigue, depression, 37%, and extreme irritability, 26%. Another study done years later by a different researcher with a totally different approach also found a lot of encephalopathy, also found 37% depression, 25% rage, irritability, rage, explosive behavior, and very similar findings. Now, children, we saw more irritability, which of course we would, because of the higher level of maturity, you see a different manifestation. So if we look at what's the whys and wherefores, now a thing that comes up is this game in medicine of objective, subjective. And what I found is the original definition of Lyme from 1975, they have these findings that are considered objective and then subjective. Now, what's objective to one doctor or subjective can be objective to another doctor depending on your training. I read a deposition of from one of the rheumatologists who sets the guidelines about how things are done, and they said, what is the extent of your psychiatric training? And he said, well, in medical school, I did a 1-month rotation through a psychiatric unit, and that was the extent of it. So if that is the extent of someone's psychiatric background, they are not trained in knowing how to make psychiatric findings or fatigue or a lot of these issues objective when really it is. So they're dismissed then as the minor symptoms and subjective and nonspecific, when in fact they are very significant. So there's this evolution that I see over time, and when I do an assessment of Lyme disease, it's very tedious. It's basically medical school 101, where we go back and we do a very thorough history, a thorough review of system, and that's really the way you need to do it. And in doing that, you see that there's this evolution over time where at first the symptoms can be fairly subtle, and then they increase and get more extreme over time. So there's a sequence, and early symptoms can be more pro-inflammatory mediated. There can be some autoimmune symptoms, and then there can be degenerative symptoms late in life. Some people with more extreme infections, they follow this course much more quickly. Now, so what causes it? How does it work? So we have to look at models, and there's this project called the Microbiome Project, and we realized that out of the cells in our body, 90% are microbial cells, not human cells. And just as we have an external environment we're in a balance with, we have an internal environment that we're in a dynamic balance with. So these microbes are always there, and some help us, some are neutral, and some hurt us, and we have to look at that balance. And that's significant in looking at new models of disease and understanding it. Now, there were old models for disease were easy to discover. It's like drilling for oil or any other discovery. The simple ways have already been discovered. Now we're deal with models for disease that are much more complicated. There are multiple contributors, multiple pathological pathways that these disease processes take, and multiple manifestations. So because of that, we have to think differently. We have to analyze it differently than we did before. Lyme is often compared to syphilis. Now, syphilis is a very simple organism compared to Lyme disease. Syphilis has only 22 genes, whereas Lyme has 132 with much greater adaptive ability. Borrelia has been around for millions of years, and it didn't last that long by lacking adaptive capability. It can adapt in many different places. Now, what I want to focus on now is about the psychoimmunology. And there are 4 articles on this that are out so far, and I think this is a big part of the future of understanding the whys and wherefores of how things happen. One thing is clinical observation, where we see someone gets a tick bite, and then you see this progression of symptoms, but it's also good to try to explain it. Now, 3 forms of Lyme affecting the brain can exist. One is what we call the meningovascular, which is where it is in the blood vessels, and by affecting the circulatory system, that in turn has a pathological effect. A second form is where the atropic form is where it's actually in the brain, and we see more of a dementia pattern. And the third is where it's in the body, and the body in turn, there's an immune reaction in the body that then crosses the blood-brain barrier and impacts brain functioning. And that's probably the most common form of the everyday form of the Lyme encephalopathy that causes relatively minor or milder symptoms in many people. Now, in looking at pathophysiology, we have the infection, and then we have the direct effect of the organism. But most symptoms are caused by immune-mediated effects. And this is one of the few things that I think everybody agrees on, is that the symptoms are immune-mediated. Although the argument is it an old infection, and then somehow this immune process just keeps continuing, or is it persistent infection? Now, the hypothesis that it's an old infection, and then this immune process continues without current provocation, is a hypothesis that a lot of people are very attached to, but there's zero evidence that supports it, absolutely zero. It's only speculation. Now, this is a white cell which should remove organisms, but Borrelia were in this and were able to destroy it. We also see that this can happen in neurons, and this is in an autopsy. So one way to think of this is think of what happens in an infection. Let's say you're exposed to infectious disease today. So there's Legionnaire's disease in a ventilation system. So now we're all of a sudden exposed. So at first we get a early inflammatory reaction, which is your early immune response. Then we get adaptive immunity, and now that adaptive immunity clears the infection and we're fine. That's the way it should happen, but somehow it doesn't happen that way. With these infections, what we often see is that there's that early inflammation, but it never evolves to adaptive immunity. Maybe it does with some people, but with the people that remain chronically ill, it doesn't. And we instead see this persistence of inflammation because there is an adaptive immunity, but instead of adaptive immunity, instead there may often be autoimmunity. So we see this impairment of the immune system that persists. Now, each infection has an immune fingerprint. And with some of this microarray testing, and this is a recent thing, came out a couple months ago, we can see these inflammatory markers that show the fingerprint of Lyme disease. So to look at this evidence for persistent infection, as I said, there's zero evidence that this immune dysfunction persists without current provocation. But there is evidence, and I think that was in the flyer that was given out, but there's also another 100 articles besides what was given out in your folder. So there's almost 300 articles now supporting persistent infection of Lyme tick-borne disease as being associated with persistent symptoms. Now, I'm not going to go into much detail about immunosuppression, immunoevasion, but realize there's a lot of capability of these organisms to survive. Think of it like when in a military operation, if we invade a country, the first thing we do is knock out the radar. And basically, you can see that microbes do the same thing. So they have these adaptive capabilities to impair the immune system to facilitate their survival, with a number of quite sophisticated capabilities. Now, the early effects, the inflammatory effects, which are also called Th1 effects, we see this fingerprint, like I showed on that microarray, of different immune cytokines and chemokines, and there's these early effects, and I don't want to go into too much detail because it might be, it's in the book and you can refer to it, but a big one, interleukin-6, which has been mentioned already, is a big marker with inflammation. And there are also some specific inflammatory things that happen with Lyme that are different from other infections. So these are basically the pro-inflammatory cytokines, the list that we see with Lyme: 6, 8, 12, 17, 18, also 10, which is anti-inflammatory, and chemokines, and interleukin-6 particularly correlates with severity of symptoms in Lyme disease. Now, the interleukin-10, which also is active, causes immunosuppression. So that's a organism survival tactic by increasing that. So we see that with these Lyme infections. In addition, there's different substances that are in these organisms. One is lipoproteins, and the lipoproteins are very inflammatory. They're 50 to 500 times more inflammatory than in other organisms, and that's one part of the inflammation. So some of the inflammation is from the cytokines, but some is triggered by parts of the cell that break off of Borrelia. The lipoproteins disseminate, so they're in the body, so you can get infection in the body, then it goes to the brain and can cause brain symptoms. So the whole idea that you need some abnormality in cerebrospinal fluid that you're only going to get 7–9% of the time anyway, in order to justify a causal relationship is irrelevant, because you can also have it in the body even when it isn't in the brain, and you can see symptoms. So we also find that when Lyme bacteria are in close proximity to nerve cells, you can see inflammation and death of nerve cells. So that was proven in dorsal root ganglions. Outer surface protein A, which is the Lyme vaccine, can cause irritation to nerve cells and death. It can also cause inflammation. And Schwann cells, which are harming Schwann cells, can be associated with demyelinating disease, and glia cells. Now, glia cells are the immune cells of the brain, of the central nervous system. So you see this, it's like a symphony where you get the inflammatory cytokines in the body, and then that activates inflammation in the brain. Another part is the biochemical piece. Now, this has to do with tryptophan and serotonin. And what happens is tryptophan is an amino acid, and our body then converts it to serotonin and melatonin, which is a good thing. But with Lyme infections, as well as with other infections like malaria and HIV, rather than being converted to serotonin, instead is converted to quinolinic acid, which is neurotoxic. And the higher the level of quinolinic acid, the more severe the infection. And that has been measured and can be measured on cerebrospinal fluid. Now, looking at the symptoms, suicide and aggressiveness, this correlates with interleukin-6, which is elevated. And studies have been done where they look at spinal fluid of people that are suicidal, and you can find a high level of interleukin-6 that correlates with suicidality and aggressiveness. So suicide attempters, we also see interleukin-6 correlate with a variety of different mental disorders. And a recent study looked at interleukin-6 as well as C-reactive protein, which is an inflammatory marker, and that correlated with intermittent explosive disorder. And also we see correlation with these inflammatory cytokines with risk cutting, with self-destructive behavior, hostility, fatigue. So that's the spectrum of some of the symptoms that we may see. Elevation of these inflammatory markers go with poor executive functioning. Now, executive functioning is your higher mental capability. It's the ability to create and sustain, monitor, and regulate goal-directed behavior. So that's a good thing to have. We all need that. It was like a quote from, it's a Woody Allen quote from the movie Sleeper. He said, "Don't mess with my brain, it's my second favorite organ." So executive functioning is a very useful thing, and that's often the more fragile and the first thing to go with these infections. There was a banker in New York who did investment and had some subtle executive functioning impairments, and then lost like $2 or $3 billion because they weren't on top of things like they used to. This is particularly significant for someone in a higher level responsibility. I had a patient once, and they did testing, and they said his IQ is 115, so he's fine. We looked back at the old IQ from high school, and it was 164. And the problem was he was doing work that required 164 IQ. And with that drop, that's a problem, and that particularly impacted executive functioning. So that correlates with inflammation, but reducing inflammation can improve executive functioning. Now, this is a type of symptom. Intrusive symptoms is something that's been puzzling me for a long time. And I've been seeing this for decades, trying to make sense out of it. And I'm going to talk about this more at the ILADS meeting in Washington in October. Here's an example. Here's a couple of patients, although I've had many, many people describe this, and they're all very similar. Frightening, stabbing, horrific images, usually a death, dying, or pain and suffering, gory, unreal, as in a horror story, faces mostly with blood or terrorized, awful expressions, visions of stabbing, killing, and it's basically these images don't seem to be associated with a particular occasion, but come and invade the privacy of my mind. Another patient, I had intrusive thoughts of killing women with a knife or an axe. Then some mechanism in my head was telling me, kill her, kill her. Sometimes I had thoughts of killing my sister's 1-year-old child and my mother. So people would get these, and it's like, where did that come from? It's like seeing a preview of a cheap horror movie that would come from nowheres. So how can you explain that? So that's something that's always puzzled me. Now, if you look at that, it's very similar to what we see with post-traumatic stress disorder. There was an ad I heard on the radio, and the ad was, if the last time you were in Vietnam, if you're a Vietnam vet and the last time you were in Vietnam was last night, call us, okay? Now, what happens there is there's this connection between memory and fear, the hippocampus and the amygdala. So there's this fear-associated intrusive recall. It could be a memory, it could be a feeling, it could be an image, and we discovered a gene that makes someone more susceptible that's quite interesting. So there's a susceptibility gene. I never thought of post-traumatic stress disorder as an infectious disease, but there's a component to it. that causes a PTSD-like syndrome with Lyme patients. So they get these intrusive symptoms, and there's this overactivity of a particular circuit and an impairment of new learning that would help correct it. And it correlates with inflammation. And what we find in treating these people is that there's a certain regime that seems to work, and often bicillin, penicillin over time gradually helps it, but we have to use some of the psych meds that reduce the severity of intrusiveness. And it correlates with C-reactive protein, tumor necrosis factor alpha, interleukin-6, the usual suspects when we think of inflammation. Now, autoimmunity, which is the other part, so this is what, rather than adaptive immunity, we get autoimmunity. There's a lot of autoimmune symptoms. There's surface glycoproteins, flagella antibodies. So a lot of the substances that we think of with Borrelia cause autoimmune reactions in patients. And we know that surface antigens, the flagella, they can then disseminate to the brain and cause autoimmune symptoms. This can be more associated with obsessiveness, tics, movement disorders, sometimes paranoia. I think psychosis may be more autoimmune. So we do find in Lyme patients there's a larger amount of anti-neuronal antibodies. That's been demonstrated, and that seems to correlate with persistent infection. Now, the outer surface protein seems to particularly cause inflammation. Now, one thing about inflammation, and there's this regular sequence that occurs, is short-acting inflammation is good. It's a little bit like jumping in a chlorinated swimming pool. It can, and then you jump out, and it helps get rid of bacteria. But if you lived in a chlorinated swimming pool and were exposed to oxidative stress 24/7, it would be quite toxic. And because there isn't that shift to adaptive immunity, you get this sequence of toxic effects. So we see these lipoproteins disseminate from the body to the brain, causing symptoms, all right? Now, in addition, Borrelia interchanges molecules with human cells, which adds to the risk of autoimmunity. And that's one other additional mechanism. And these lipoproteins can go to the brain, be quite active. So the problem is now, that's just Borrelia, but we have all these other tick-borne infections, and who knows what else. Next year there will be a new, or this year there will be a new tick-borne disease that's discovered that's really been there for a long time. And it's not just all these effects, but the interaction of these effects with each other. It's not additive, it's interactive. So it's complex interactive infections that are the culprit here. And these other microbes have other immune effects in addition to the Borrelia that are immunosuppressant or causing immune symptoms. So that further adds to the complexity of this picture. Now, autism for a minute. There is a fair amount of evidence that certainly autism goes with this complex model, like I showed that diagram before. There's multiple contributors, multiple pathways, and multiple manifestations. And we have an article coming out where we looked at autism, and a 31 and a 34 bands were particularly significant in being associated with autism. And we found that 96% of people of 92% of autistic cases associated with Lyme, we saw reactivity 31 and 34 band. So there's around 15 articles where we've looked at autism and Lyme and tick-borne disease and the association. And this is that article that I said. Now, if you think 31 and 34 are candidates for the vaccine, so that raises some concern. If we immunize people, could we be creating an autism epidemic or worsening it already? This is an example where with 34, OSB, reactivity to OSB correlates with severity of autism. Now, dementia. One thing I found is when I practice in New Jersey, people come to me from a lot of different places, and I see a lot of panic attack disorder cases from southeastern Pennsylvania, but in the Chesapeake Bay area, you see a lot of cognitive dementia cases for some reason. It seems like the strains that are here can manifest more that way. And that correlates with my old experience here at the Eastern Shore State Hospital. So we can see the rapidly progressive dementia. And this is someone who may be 40 years old, and they sometimes frontal temporal dementia, really rapid decline. I think there it's more the microbes are within the central nervous system, but then you see this slowly progressive encephalopathy that follows a different pattern. It's, like I say, more common. Now, there really is an awful lot connecting Lyme and dementia. I'm going to go through this fast. It's in the book, but I'm showing, like, here, 10 slides on Lyme and dementia. So it's quite strong. Now, with violence, that's an area I get involved with a lot. And think of the brain as a hierarchy of functions that's evolved through evolution that's based on stimulation inhibition. So there's higher levels that are inhibitory, stimulatory, and they're in balance. So you have your cognitive areas at the top, then the emotional mammalian brain, and then the reptilian brain, the brainstem. Plato really described it quite well, where he described human functioning as like a charioteer with horses. And a charioteer represented higher cognitive powers, horses' emotional powers, trying to bring that into a unified team, and that's the challenge. This is a breakdown of some of the circuits. See, with something like violence, you could have an injury here, an injury here, an injury here, and still get violence. So it's how these circuits balance each other. And this is a brain scan of a normal versus a murderer. And you can see that there's differences where certain areas don't work. Now, if we look at what happens, a lot of people get like those intrusive symptoms and they just annoy them, but they don't act on them. Why is it that some people then act and become homicidal or explosive rage? So it's the balance of contributors and deterrents. But the more harm you have to these circuits, the greater the risk. One way to think of it is if you take 100 people and shoot them with a shotgun, they all have a different injury. You see common patterns, but there's all variation. So when we look at violence, and the average patient who gets Lyme disease is not violent, but a unique combination of impairments can do it. So for instance, the impairments that may increase the risk can be cognitive impairment, sensory hyperacusis, decreased frustration tolerance, decreased impulse control, intrusive symptoms, particularly if they're aggressive or sexual aggressive, homicidal preoccupations, mood instability, depersonalization, dissociative episodes, paranoia, psychosis, social anxiety, making someone socially isolated, altered sexual behavior, decreased bonding capacity, that's a major deterrent, loss of empathy, impaired facial recognition, impaired emotional insight, decreased tolerance to the effects of drugs and alcohol. So when you get someone who has too many of those symptoms, that's a dangerous combination, and that sometimes happens, unfortunately. Now, if we look at assessment for a minute, this is the two-tiered testing. And if you look at the bottom, and I took this from the website of the CDC. At the bottom it says surveillance. This is for surveillance case definition. Surveillance case definition establishes uniform criteria for disease reporting and should not be used as the sole criteria for establishing clinical diagnosis, determining a standard of care, or guidelines for quality assurance or standards for reimbursement. Now, this is treated like a sacred cow, as though, and the people that created this have patents, and I don't think any of those people within the CDC have any patents with PCR or Lyme culture like they do with this. But instead of it being a sacred cow, it's been giving us a bum steer for many years. Now, if we look at this test, there are 3.4 million Lyme tests done, mostly this two-tiered ELISA testing. And that picks up 30,000 cases a year. So that's less than 1 in 100. So how useful is this test? And whether we cite the study 56% or 46%, it's useless, it's dangerous. We should do away with it. So, and now the CDC says there's at least 300,000, and there's probably more. So but yet a big problem is the average doctor in the community will do this test as a screening test, and when it's negative, say, proof they don't have Lyme, move on, think of something else. And that's quite dangerous. So in summary, and maybe just to say a few words, a big thing is do a thorough assessment. That's critical. And consider the psych symptoms. And I have on my website, an assessment anybody can do. And it takes about an hour and a half to go through it. It's very tedious, but that's what you have to do. That's what you have to do instead of the two-tiered ELISA. And then with treatment, you're basically treating two ways. One is you want to reduce the chronic stress and the sleep disorders that impair immune functioning, that impair adaptive immunity. So antibiotics are one treatment, and symptomatic treatment that contributes to persistent of the impairment of immune functioning is another treatment. You want to also think of that strategy as well, particularly sleep disorders, failure of delta sleep, and that's when adaptive immunity would tend to occur, is in delta sleep. So promoting delta sleep, treating the anxiety, depression, realizing that a lot of Lyme patients are quite sensitive, drug sensitive, and we have to start out with lower doses. And that's the basic strategy, and that makes a big difference when you combine those two approaches. So basically, there's a lot of immune effects causing Lyme, tick-borne diseases. They're quite complex, but they can be teased out and explained. They contribute to the cognitive impairments, dementia, depression, anxiety, autism, violence, and other psychiatric symptoms. And this awareness helps us to prevent many of these conditions. Now, this is wonderful to think we have insight to prevent a lot of chronic disease, a lot of pain, a lot of suffering, violence, death, particularly like with the autism, to prevent that, it's catastrophic. The violence, there's people alive today that won't be alive at some point in the future because someone with impairments associated with this was not adequately treated. That's tragic. We can prevent that. So Sir William Osler, the father of American medicine, stated, "He who knows syphilis knows medicine." Now, as I said before, syphilis is a rather simple disease. Lyme is much more complex. So we have to twist that quote around and make it a little bit more complicated for that reason. So instead we can say, he who knows Lyme disease knows medicine, neurology, psychiatry, immunology, psychoimmunology, ecology, law, politics, and ethics. So in the future, we want to go further with this and understand this more. It's understanding the link. A problem is that immunologists, rheumatologists, people that study the immune system don't know much about psychiatry, and psychiatrists don't know too much about immunology. So we need more crosstalk between those two disciplines. It would help to understand this, and it would give us a lot of opportunities to prevent things that we otherwise just accept. We shouldn't accept chronic mental illness as just something that's there. We can prevent it, treat it, and understand it better. So thank you for your attention.